So now we're going to get into really a lot of the meat of the talk here. And specifically now we're going to talk about what are the different strategies for antipsychotic switching. This is an extremely important clinical question. There's not necessarily an absolute right or wrong way to do the switch. It depends on a number of clinical and patient factors, but my goal here would be to discuss with you what are the different ways that we can make the switch. So the first switching strategy is just an abrupt switch. That is, the pre-switch antipsychotic is stopped immediately, and then the new antipsychotic is started immediately. So this is a very common approach in clinical trials. So for example, a patient is taking 400 milligrams of quetiapine. They are going to be switched to 15 milligrams of aripiprazole. And in this abrupt switch scenario, the patient is simply advised to go ahead and stop the quetiapine. Don't take any tonight. And then tomorrow, you're going to start on the new medication, the aripiprazole. This method can be good in terms of trying to mitigate a potential serious adverse effects. An example being a patient we're concerned about the possibility of agranulocytosis with clozapine. We would simply immediately discontinue that medication. However, as you can imagine, it carries a higher risk of withdrawal symptoms if we just abruptly stop the pre-switch antipsychotic. But this is a very common, straightforward approach to switching. Stop one, start the other. A second strategy is the so-called cross-taper switch, which is arguably the safest way to prevent relapse, that is, illness exacerbation. Despite a gradual cross-taper, drug-drug interactions are still possible. This is recommended by many experts in the field. The typical time period for such a switch is 2 to 4 weeks. So, for example, a patient is taking 20 milligrams of olanzapine at baseline. We decide to switch them to aripiprazole over a period of 3 to 4 weeks. And so what you might do is taper off of the olanzapine by 5 milligrams to 15 milligrams daily on week 1, 10 milligrams daily on week 2, 5 milligrams daily on week 3, and then discontinuing the olanzapine on week 4. And then on the flip side, the aripiprazole might be started at 5 milligrams on week 1, 10 milligrams on week 2, 15 milligrams on week 3, and then up to maybe a target dose of 20 milligrams on week 4. And so that's the gradual cross-taper switch. A third strategy is the so-called taper switch, which involves immediately starting the new antipsychotic at the target dose and then gradually discontinuing the pre-switch antipsychotic. So, for example, 20 milligrams of aripiprazole is started immediately, and then the olanzapine is tapered off by 5 milligrams per week over a period of 4 weeks. So when you compare this taper switch to the cross-taper switch, there's less risk of withdrawal symptoms because the new antipsychotic is started at the target dose. However, that also may increase the risk of drug-drug interactions. And then the final switch strategy that we'll talk about is the Plateau cross-taper switch. This is a very common approach when we switch patients to clozapine. In this scenario, the new antipsychotic is started at a low dose and gradually increased. And then there's a period where there's a plateau where the patient is being treated with both the pre-switch and the new antipsychotic at the same time for a period. And only then is the pre-switch antipsychotic tapered off. So, I alluded to clozapine. It's not uncommon that when switching to clozapine, for example, a patient is continued on their pre-switch antipsychotic as we're increasing the dose of clozapine. And only after we get to doses of, between, say, 100 to 200 milligrams of clozapine, do we then start tapering the patient off of the pre-switch antipsychotic. So the key points here, the two most common switch strategies include the abrupt switch and the cross-taper switch, but other potential strategies include both the taper switch and the plateau cross-taper switch.